sir. Yes, sir.
So thank you for that excellent session. And from one excellent session, we move to another remarkable session, and probably one of the highlights, of WIROC 2022, learning about earning. So we have all the stalwarts of orthopedics. I'd like to invite Dr. Ram Chadda and Dr. G.S. Kulkarni sir to the dais, and our chairpersons for this session, Dr. Ambardekar and Dr. Raju Pathak.
Morning, everybody. As we await our chairpersons, Dr. Pathak and Dr. Ambardekar, to please join us, I would also request the three panelists, in no particular order, but the order is old, older, and oldest, wise, wiser, and wisest. So we have Dr. Pichai Suryanarayan from Chennai, originally from Mumbai. We have Professor Nandu Lad, Mumbai, and Professor G.S. Kulkarni, Mumbai, and now Miraj. So we have a lot of gray hair, we have more gray hair, and we have all of us seated here to share what these three wise men have learned in many decades of their practice. We have two lines. One, which is the title of our discussion today, which is Learning Above Earning. So these three wise men are going to share those experiences where they've actually earned not in cash, but in kind, where patients have taught them something which they need to share with us. And finally, they will tell us why each one of them over the years has worked more for outcome rather than income. I welcome our two chairpersons with their opening remarks.
Hello.
We would then initiate these three stalwarts sharing their experiences. The order that we would go is Dr. Suryanarayan would make a presentation, and then we would have an open house discussion, followed by Dr. Nandu Lad, who would make a presentation, followed by an open house discussion. And finally, Professor G.S. Kulkarni making a presentation, having an open house discussion, and being the main convener, giving us a take-home message thereafter. Thank you all for being here, and stay on. Over to the chairpersons.
Welcome, everyone. I would suggest it should be learning before earning. I think you should not try to earn before you learn. The new trend is earning before learning. So I want to listen to all these stalwarts clearing the misconception about orthopedic learning and earning. So I would request Suryanarayan to come and give his talk.
A very good morning to the WIROC organizers, Professor Chadda, and it's indeed very heartening to see all my teachers on the podium after a long time. Professor Ambardekar, Raju, my good old friend, Professor Lard, Dr. Kulkarni, and what can be better than this? Just to be sharing a dais and a podium with all the stalwarts. Indeed, Raju, you rightly said there's a lot of gray hair here to earn. And Ram, thanks for putting this up together. I think I look at it as a philosophy. It's more than learning about earning. It's not a point because these things grow. You start learning about when you start doing. I think money and the earning flows with time. But there needs to be some sort of definition with regard to where you focus all this time. I'm going to take a representative case first and then just let you go through and then we can probably discuss later on. This was about a 50-year-old gentleman who had presented in 2013 and then he had the index surgery by the great Doyen, Professor Dholakia at that time. Dr. Lard would allude to this. This is a triad hip which was done. The lab profiles were normal. It looked like a very clear aseptic loosening. But if you look at the pattern of aseptic loosening and the cortical loss, I think there is something more to the story. But if you make it amiss, I think then you take it as a pure revision. What's the problem? So, being a novice, very naive, I just took for the exposure. There was an intense bleeding, very friable tissue right at the skin level. So, I was wondering whether it's a malignant tissue. We abandoned the procedure, did the arteriogram studies, and then we blocked the bleeders. And then in the meantime, we had taken a biopsy, but it was not a good because in view of the severe bleeding, it didn't show anything much at that time. We rushed in and then went off to dissect that segment, which was hardly doubtful, and then we put in a proximal femur prosthesis. To me, retrospectively looking back, this was the error one, that we didn't fully go into what the source and what the tissue is, and this reflected this. Patient was comfortable, of course, functionally. You can see the coils on the medial side, and the histology subsequently sent again was totally inconclusive. Year 2014, you find the progression in the radiolucent lines on the distal side. Was wondering, we thought it is fixed, though of course, most of the tumor prostheses don't have a great history if you look at them beyond 5 to 6 years. But even within a year, having seen this, it sort of made me rattle on this. We looked at it, but again, just kept observing him for a little time because the symptoms are not so severe. But you could find some amount of sinkage, some periosteal reaction forming along the junction. So that gave the suspicion of some element of instability. The radiological changes continued to be progressive. The pain and discomfort continued to be progressive, and he now started a little lurch on walking. We did the PET scans, did not show any huge hot spot as such to depict any infection or any activities. So depending on entirely relying upon just investigation sometimes take you on the wrong path and then you end up somewhere else. So the question again was, I was trying to analyze mechanically, in which case functionally we didn't find anything. When we saw mechanically, is it instability? And there is always this aspect which subsequently I've learned is that the length of the stem versus the length of the proximal body has a play. If you have a very long proximal body which is rather very heavy with the Vitalium or the stainless steel, a short distal stem is a problem. There is a lot of cantilever movement and they tend to rattle and loosen up very soon. So that now people have worked out and in the mechanics, the engineers are working on proportion of the ratios of the stem length required for stability. So that was lesson number 2. So the error 2 basically here was the not calculating the ratios of the proximal body length and the stem length, which should be optimized for the fixation, whether you do cemented or whether you do non-cemented. So this was the picture with no progression, and then in 2016, what we found was, again, this started loosening and getting into symptoms. So we said there's something that meets more than meets the eye. We changed the stem again. This is a picture post-operative where a longer stem was used with a proper cementation, but the symptom didn't subside. And what we missed was the fact that in medicine, sometimes we have a lot of intrigues that come. Like here, for example, the histology is inconclusive, the septic profile is negative, otherwise a healthy gentleman. Where are we is a question. Second point one could raise is why we did not change the socket after about 20 years. So that makes a difference, because we have seen that the isoelastic cups continue to work for a long time, but at 20 years is a good enough time where probably we should do. So these were the pictures, but the thing is the expanding soft tissue mass reappeared again. And within a short while you found it just growing all over the place. Without a diagnosis, without a histology, it was again intriguing in a sense. It was there 2-3 years before we resected the whole thing, it has reappeared. Had a discussion with the oncologists, but they were also not very clear. They said there could be features which are suggestive of a sarcomatous change, which seemed to be in order. But with this huge mass, the patient was also getting fed up, not very reluctant, and we left it at this for a few more months. But time wouldn't go very soon because of the tissue instability. The whole thing fell apart and it dislocated, which now speeded up the need to intervene. We had an extensive resection with the help of the oncology group. We changed and entirely revised the thing. So the third revision was extensive resection by the oncosurgeons, then of course the usual reconstruction of the socket with a trabecular shell with a cemented dual mobility, proximal femur prosthesis, and a mesh reconstruction. So this is just a few snapshots. TM shell with the evolutus uncemented dual mobility was put. To reattach the abductors, we used the Marlex mesh, and we did this. This is the picture now. Was at 2017 and 2018. But the saga did not end there. Unfortunately, through all these surgeries, at last we caught up with the infection in 2018. And he had repeated but at this time, due to some reasons, I could not proceed with the treatment since I was away. And one of the colleagues and friends whom I admire here in Mumbai, actually, I took him, asked him to take over the case and if he could help us. Repeated debridement and spacers were done, multiple drugs, fungal infections treated, but it took almost 3 years to get hold of the infection. And presently, this is the status after 2 or 3 rounds of spacer implantations with antibiotics, systemic therapies, and systemic chemo. So this is where we have ended now at the end of 6 to 7 years. And these are the pictures, a significant deficit, proximal bone situation, and acetabulum, which is this. Just the other day, just before coming, I just messaged the gentleman. I keep in touch. I just asked him, how are you? And he said, sir, I'm fine now and I have no problem, but please operate me if possible. We can well understand the morbidity of such a situation. So I think I said we certainly shall have a look at it. It just says, patients come to us with a hope and a faith, and we can't betray them and we cannot give up. It's very frustrating. It is not the matter of what you earn out of the case, or it never occurs to you, because you are constantly thinking of how best to get or how fast to get him back on the feet. And that's the only thing that drives you to keep doing and taking up these challenges. Of course, sometimes you are left with the constraints of the spending from the other side, not the earning from me, but the spending from the patient. That's where the empathy comes, and you try to help them as much as you can. But so the learning, I think in this situation or a case like this was plenty. What all things I could have done better? That's the first question that comes to me right at the beginning. Probably discussion with the peers and a detailed review. Though we had small meetings, it could have been a broad base with multiple opinions, so that probably we could think out of the box. Probably the polyethylene, the cup should have been revised since it's been inside for a long time. And always X-rays do not reveal all. We all look at osteolytic lines, we all look at dislocations, we all look at all the other features radiologic, but there is much more to the story. So it is very, very imperative that probably we all completely evaluate with all the available modes, if necessary, whatever that takes for you to come to a conclusion and whatever it takes for you to get a sort of a good outcome of this. I just realized from this case, after 7 years and still running, now I'm thinking of what the final next thing we do. You realize there is something controlling from the above too in all these cases. With all these interventions again and again and again, At least I'm still not medically gone into a medical liability with this gentleman who has been extremely kind and nice. So there's a goodness from both the sides which should be done. The patient is fortunately healthy, otherwise not being totally mobile. He's moving around with a walking frame. And with all this, after 3 years, we have got some hand on the infection, and the infection is controlled. So I think, I'm sure my senior teachers would have even more wiser words on this, but what I felt was, I think we have to be modest, we have to be straight, we have to look at all the other aspects. I think that earning comes, what you do or not with time, earnings always will come, but the focus needs to be purely on the outcome and see what is best. Our own old things may not work, things keep changing at all the times, and updating ourselves with what's new, what's good, and talking to people without being skeptical. Your failure is part of all of us, and we have got to accept it. Talk to our colleagues, talk to our seniors and everybody. Get the best inputs before you plan a final output. Thank you.
I think we have about 3 minutes before we go to the next speaker. So anyone in the audience having any question, any suggestions, please? Please raise your hands.
Any comments from?
Suri, I think when he came to, he already had listening a lot of proximal femur, right? No. First X-ray you showed.
Yeah, that was an erosion.
Yeah,
But
erosion.
Because of the mass which was all around the tissue.
See, what I have found is the history of this triad stem has not been so bad with me.
Correct.
But I think the problem comes that our patients in India, if they don't have pain, they don't report. If they report, this disaster could have been averted. I do agree that isoelastic stem failed, cup remained. Rob Matthys cup remained.
Agreed.
And wear rate was very less. So I think by the time he came to you, his proximal femur was gone. But I have a feeling that all the young people must insist patients come for follow-up every year. For first 3 years, every 2 years, for next 3 years, they must come. Because then this sort of thing could have been averted. This is what I have followed. And then when you maintain a good record, I have seen that disasters become less.
I think that, may I add a statement, a sentence? I think this is a clear lesson to all people doing joints. Is once your patient is always our patient. For lifelong, it happens. Sometimes for the good, sometimes for the not so good.
Now I request Dr. Lad to give his presentation.
Dr. Ambedkar, Dr. Pathak, my learned colleagues, I thank the organizers for inviting me. I'm an old person. A case which I learned more than I earned. I show you a 48-year-old fisherman and motorbike accident 3 days ago and had no treatment. He had some putties. And if you see, he had a massive soft tissue injury. And see his fracture pattern. Now we have the pseudoarthrosis. This is an area where pseudoarthrosis is extremely common. So to think about it and plan very well. So my issue was not much of the bone. My issue was much of the soft tissues of 2 reasons: devascularization and possibility of revascularization. Analyze his fractures. He has a severe comminution. He has a lateral translation. So gross instability as a soft tissue compromise. But look at his mortise. His mortise isn't too bad. So I think always have 3 looks at the X-rays before you decide anything. What would be the surgical plan? As all of us think, do a lateral pillar stabilization, Temporary X-fix, naturally your comminution medial loss, so definitive fixation of the tibial medial fracture, bone grafting, primary or secondary, or maybe synthetic bone. So I thought about it. I felt in this case we have to be very judicious, and if I rush up, can we have a problem? I think that injury leads to further trauma to the already damaged tissues. You need to devascularization of bone fragments because of surgery. Your loss of vital bone-inducing substance and your increased chances of infection. So what are the challenges? Look at the patient, not at the X-ray. His ejection fraction was 20%. He was diabetic and he had elevated serum creatinine. So I said, we have to be careful and he needs a primary medical care. So what did I do? I said that let me get it aligned, and my experience shows that temporary K-wire fixation in the metaphyseal junctional fractures to cross probably holds it. Naturally, lateral part was not too bad, so I put a lateral plate and put 2 K-wires in cross-section. I got fairly good stability. I noticed that there was a medial bone loss. The wounds later on showed, though looked good, but I was worried about it. Can I do the intervention? And I said, no, I should wait. I did see where I put a plate, some amount of weight in that 3 weeks. And I said, I dare to, but today we have a possibility of collagen dressings, and you should use this. And I was very impressed that it did heal very well. What happened? The wound started healing. He was very comfortable walking with crutches. Having seen this, at the 6 weeks, I removed the fixator and told him we should be doing surgery. He says, no, sir, thank you very much. I don't want surgery. I also discussed with the physician, and he asked me, it's wise if you defer it. So I used the famous patellar tendon bearing functional cast. So at 2.5 months post functional cast, this was his position. There was no infection. And that medial bone, loose bone, you said was a sequestrum. It was not a sequestrum. Interestingly, you could see an anterior healing and a lateral healing. So, this point, can I do a medial stabilization? As I said, patient and my physician colleague said, if possible, avoid it. I want them, this may not heal. At 4 months, look at what's happened. Complete anterior healing, excellent lateral healing, some defect on the medial side, but clinically he was very good. Clinically he was very good. So, he removed that plaster at home. And he came walking. I was surprised. The main was, I was impressed with his gait. A good patient whom you communicate is always a good guidance to you. So, anything you should do should be acceptable to the patient, not to the surgeon. We use that, this is acceptable. No, it has to be acceptable to the patient. So, at 6 months, you still see some defect, but a complete osseous union. Did he restore to good function? He restored to good function. He started driving motorbike, went on a ship again. I was not a very rich man. I became wiser. For 2 reasons, I learned to talk to my patients. I learned that I must discuss with my physician. And I learned that probably together, if you have patience, perseverance, persistent, it pays. Lost money can be earned. Experience enlightens forever and is a sure way to wisdom. And this is Lionel Messi, who for 10 years put on efforts, and that's the reward is God. I thank you for your attention.
Thank you, Dr. Ladd. I would like to congratulate you on your excellent result for this. And I would like to ask you whether you would have done anything different in retrospect.
He wants to know whether the patient was right or you were right. You would have done
I
anything
think,
different. Probably
I-
patient teaches you so many things.
Because I was patient, I had patience,
Yeah.
so I listened to wise counsel.
Okay.
See, what happens is, many times in our practice, we try to sell an operation to the patient. Modern shows this, we have modern implants, because my fear is, we are driven by market forces today. Not that I was one of the person who believed that very strongly to begin with. But I think he should balance all. The technique, technology, patient, our experience, put together. But good follow-up. And every time put check. Clinical check is very important. Don't rely on the X-rays. Because that area is very sensitive area for pseudoarthrosis. Very, very sensitive area. But remember, revascularization, you should not touch. The local healing process is superb. And see the point of bone. So it's junctional bone, it could lay down a good quality bone. And because he was walking, that little, stress produced an osteogenesis and it healed. So I think truth is somewhere else. Surgeon must use an implant to help the fracture to heal. That's my philosophy. Today people feeling that you use an implant and fracture will heal. No, it's a purely temporary process, the plate fixation. And how you do it.
Dr. Ladd, I still remember my teacher, Dr. Bowdekar, saying, probably he had a good sixth sense, which probably comes with your experience, and procrastination gives you an answer to so many questions. In this case, you procrastinated because of your good sense and good advice from the colleague, and probably you will ended up with good results. If you had plated it, maybe it would have been a disaster.
You're right, because he had such an extensive injury. Actually, his motorbike fell on his leg. So that crushing, as I look back, that local crushing to revascularize it were very important. I think you become wise, and as you become old, you tend to become more conservative.
Thank you, Dr. Ladd.
Thank you.
I would like to invite Dr. Kulkarni to narrate his experience.
Dr. Ambedkar, Dr. Pathak, and friends, during my long life, what I have learned is one thing. That is, if you are academically interested, if your knowledge is perfect about your subject that you are handling, money follows. You don't have to worry about money if you are really academically interested and taking care of the patient to the perfect. This is a 56-year-old man, 1-year-old non-union of subtrochanteric fracture. We treated him with DCS and it miserably failed. This was in 2012. We learned from this case that dual implant worked here, that we just added an anterior plate to this, bone grafted, and a lag screw. And he had full function. Here, dual implant worked. This case stimulated us to study why, how, all about dual implants. I will show you that the force from T10 acts on the medial side. If you see the femur, you see from head to this, it is on the medial side. 70% of the weight passes through the medial condyle of the upper end of the tibia. Now, when there is a fracture, the compressive forces act on the medial side, and therefore there is comminution, and tensile forces act on the lateral side, therefore just a fracture. So the lateral plate acts on a tension band principle. Therefore, integrity of the opposite medial cortex is crucial. Both columns need to be stabilized. This is columnar dual implant concept. Both columns are restored by either a bone grafting, fibular strut graft, allograft, or from the body. And you can add a plate, but in the femur, medial side available only distally 10 to 12 centimeters. Therefore, we can add an anterior plate, and nail buttresses both cortices. Simple fractures you can treat with simple implant. One implant, that is nail or a plate, can work in these cases, but in complex fracture need dual implants. In the femur, you can have comminuted medial wall, subtrochanteric fracture, shaft or distal femur, segmental fractures, non-unions. In tibia, Shajkar type 5 and 6, comminuted shaft, non-union, complex splenion. All these need dual implants. How dual implants work? Biomechanically, plate protects the rotational and axial stability, nail prevents bending. So they complement each other. Dual implants are a super construct and union is assured. Types of dual implants are nail plus plate, nail plus X-fix, plate plus X-fix, dual plate or dual nail. Now see this case. This is a very interesting case. This patient, adult, 9 months old, non-union of the shaft, which was treated by nail, which was wrong entry point for this nail. And we treated it with a compression plate and a nail. Here, the compression plate acts on the principle of compression method, that is absolute stability, and nail works on elastic stability. So this is a combination of compressive forces and elastic forces, elastic method. This is not accepted by AO. AO says that you should not combine these two methods of fracture fixation because biomechanically and biologically they are different. But in India, we are using this recently for the last 10 years. I see conference in many conferences that complex fractures are treated by combining a compression plate and a nail. So this is really needs a real deep study. Now, Kodi Kojima in 1917 coined this word, combining compressive method with absolute stability and elastic method with relative stability, what he calls it absolutive fixation. This really needs deep study. See this case, severely infected non-union was pouring from multiple sinuses, multiply operated, came to us with, we treated with debridement and antibiotic nail and X-fix. Again, combination of the two. Ilizarro gives compression and nail gives elastic. Again, when the infection was under control, we treated with nail and a plate. This is a complex segmental fracture with comminution, treated with long plate and a nail. See the union. This is a case of non-union of neck femur and shaft This was treated with a long stem prosthesis, but it failed to unite. So we had to add a plate, long plate on this side, combining the two methods again. Comminuted subtrochanteric fracture with osteoporosis. I will run through the slides because I have to present a large number of cases. So long nail and a plate united. But here the same thing failed because we used a short nail. This is what is needed was a long nail. So when we added a plate and a long nail, it united. Again, comminuted subtrochanteric fracture, nail plus plate, union. Medial void needs plate and a nail. No, this is a severely contaminated open fracture. Delayed presentation came after 1 week and internal fixation was risky. Therefore, we used as LCP as an external fixator and added a nail. It united. Complex proximal tibia, we added a dual plating, union. Segmental proximal tibia, again, dual plating, united. This is a case of non-union, 7 months, upper end of the tibia, dual plating, union. Segmental comminuted tibia, femur, single implant failed here. You can see that the nail broke and went into non-union. Therefore, we had to add dual plating and bone grafting, shingling, united. A 14 months old untreated non-union, dual implant with compression and shingling, bone grafting, united. Shaskar type 6, note the intra-articular fracture with extension into the shaft, dual plating, union occurs. So the take-home message is for complex fractures and non-union, consider modern dual implants. Indian traumatologist should study this absolute fixation, which is a very controversial topic. We Indians have a large number of cases, intelligent brains, and we have, but what is lacking is a publication. So if we traumatologists combine and do a multicentric study of very big, high volume hospitals, then we can teach the whole world. So what is more important today is learning more than earning. Thank you very much.
We have just 2 minutes left. Any question? Last chance from the audience.
Dr. Kulkarni sir,
Very short.
I saw, oh hello sir, here.
Where? Oh, yeah.
So, very good result, dual plating. Wonderful, very well accepted. I saw in patients, some patients there is right angle plate and there is parallel plates. Any study by you or in literature, which is the best? Or it depends upon fracture configuration. Any mechanical study has been done result-wise, mechanic-wise.
What is the question?
Question is right angle plate or parallel plate. Which one is the best?
Parallel plating is necessary. For
In
these
some cases I saw there is right angle plate as well. Lateral plate and then the anterior plate in different fractures.
Okay.
That depends upon fracture configuration or is there any choice?
Doctor,
No,
I'll share my, long ago when you do not have an interlocking, we used to use our Wunschner nail for lower third fractures. And we used to use an anti-rotation plate at the junctional fractures. The question is, on table stability you obtain by minimal intervention, and see any gap, fill it up. You must ensure stability. It's surgeon who uses a plate. There is no standard and cookbook what it does. Today, you get a pillar stabilization both. For comminuted fractures, where muscle forces. Now, he showed a lot of cases are reverse oblique fractures. Here the question is not only fixation. How do you balance the deforming muscle forces and rotation? So surgeon decisions are on the table. So implant you decide. There is no cookbook. There is no research related to that. Adequate stability on the table and ensuring no bone defect.
Thank you, Dr. Lad. I think we are coming to the end of this session. Dr. Kulkarni's new idea is welcome, and I think it will be discussed extensively. We should have a symposium on double plating, and I think it is evolving. It's not yet proved, so everyone would have a different opinion.
Yes.
So I hope that next time there is a symposium on double plating.
Yeah, sure, it is a
So
very
thank-
Pathak, today the world is moving towards sliding plates. Don't disturb the tissues at all.
Sir,
So,
but
you are not
can
worried
put-
about the reduction, alignment in the rotation and this. So many of those cases we have treated where we slided the paste, didn't open it. Only incision at the top and same as shown union.
Sir,
What he has shown is failed, where initial intervention was not good. So today, if you really see world literature, the sliding plate has solved a lot of problems except for the reverse oblique fracture. Reverse oblique fracture, I agree with him that you have got to use some medial implant.
anyway, we come to conclusion of this session. I
Thank
hand
you.
over the mic to Dr. Ram Chedda.
Thank you
And
so
Thank
much.
you very much to the speakers. See you next YROC. Thank you very much.
Thank you, Dr. Ambadekar. Thank you, Dr. Raju Pathak, for chairing the session. Thank you, Professor G.S. Kulkarni, Professor Nandu Lad, and Dr. Surya Narayan. I'm sure we learned a lot. And before I hand over the proceedings to the Master of Ceremonies, I think the three lessons we learned, Professor G.S. Kulkarni taught us that as we progress, we need to learn, unlearn, and relearn. And that is the way forward. Path breakers like him are the people who have become path makers. As far as Professor Lad is concerned, he made a very important point that we should not sell an operation to the patient. We should let the patient buy the operation. And thank you very much, sir, for telling us that, and it's extremely important today. And Professor Surya Narayan, he said something which is very close to our heart, and I quote Winston Churchill when he said, "Success is not final, failure is not fatal. It is the courage to continue that counts." Thank you, gentlemen, for all being here.